So Staphylococcus, what will differentiate between Staphylococcus and Streptococcus is the catalase test. So Staphylococcus is catalase positive, then Streptococcus is catalase negative. Okay, I want you to remember that. Okay, so this is the Staphylococcus. As you can see here, they are gram positive, so they are purple in color. And if you are to look at the pattern, they're in clusters. Okay, and you see these are the clusters compared to Streptococcus, which are in chains. Okay, so the family is Micrococcia, consists of gram-positive cocci arranged in tetrads or clusters. The genus is Staphylococcus. So how to remember? Staphylococcus is derived from Greek, coming from a bunch of grapes or berry, meaning bacteria with grape-like clusters or berry, as you can see here. So this is very high yield. They can bring for you this slide, then they ask you questions regarding this. So you have to remember, if you see gram-positive in clusters, Staphylococcus. Okay. Then classification. So there's this classification we have. After you got Staphylococcus, we have different species. We have Staphylococcus aureus, Staphylococcus epidermidis, Staphylococcus saprophyticus. So the test we do is coagulase positive. So after doing coagulase test, if it's positive, it's Staphylococcus aureus. If it's negative, Staphylococcus epidermidis or saprophyticus. And then there's another test we're going to do to differentiate these two. It's known as the novobiocin sensitivity. Epidermidis is sensitive, while saprophyticus is not sensitive. We're going to get into that. But basically, based on the pigment production, one thing you have to remember, Staphylococcus forms golden yellow pigment colonies. Okay, as you can see here. Then we have these other ones, but they're not pathogenic. Albus, citrus. So what we are really interested in is Staphylococcus aureus. Then the non-pathogenic, these ones, they are normal flora in the skin and wherever they colonize, okay? Then based on coagulase productivity, as we had said, Staphylococcus aureus is positive, the rest is negative. So take home here, golden yellow pigment colonies, Staphylococcus aureus, and it is coagulase positive. Okay, let's start with Staphylococcus aureus. Its natural habitat is the nostril and the skin. Morphology, gram-positive cocci, 0.5 to 1.5 micrometers in diameter, occurs in groups, also singly and in pairs. So if you just see clusters or in groups, we know that is Staphylococcus aureus. It is non-motile, meaning it cannot move, non-sporing, so it does not form spores, and few strains are capsulated. Though, when we're classifying Staphylococcus aureus, we usually say it's non-capsulated. Just very few strains are capsulated. Then aerobes and facultative anaerobes. What do we mean by facultative? Facultative means that they can survive with or without oxygen. Then obligate. If you hear the word obligate, let's say obligate aerobes, that means they require oxygen to survive. If you hear the word obligate anaerobes, they do not require oxygen to survive. Facultative means it can survive with or without. Optimal temperatures for growth, 37 degrees, pH 7.5, so around neutral or slightly alkaline. Then on nutrient agar is where they form the yellow, golden appearance and opaque colonies, as you can see here. So this is just nutrient agar. Let's say you took a specimen, you put it here. This is how it will look like. Okay. Then on blood agar, this is zones of hemolysis. So hemolysis means destruction of red blood cells. So it forms something we call beta hemolysis. Okay, we are going to see that in Streptococcus. But if you were to look at it, you can see that it is completely hemolyzes there. where the colonies have grown. Okay. And the blood agar, we usually use the sheep or rabbit blood agar. Okay, this is known as beta hemolysis. Then on McConkey, so anywhere you see McConkey agar, normally it's used for gram-negative bacteria that are lactose fermenters. Okay. So I want you to remember when you see McConkey agar, remember that these are testing for lactose fermentation. And normally what happens is the McConkey agar, when it turns pink, is when you know that there is lactose fermentation. So in Staphylococcus aureus, it can be used, but it is not a confirmatory test, but it is also a lactose fermenter. This is just as a by the way. Then in mannitol, this is very high yield. As you can see, mannitol is usually pink. Then when you put the Staphylococcus specimen here, it usually turns it to yellow, okay? So if you see like a pink background and the yellow, you know that this is Staphylococcus aureus, okay? As you can see, it differentiates it between the other species of Staphylococcus. Staphylococcus aureus is the only Staphylococcus that is mannitol, that ferments mannitol to put this or to produce this yellow pigment, okay? Then methicillin-sensitive Staphylococcus aureus, also known as MSSA, is useful. Sorry, MSA, which means mannitol salt agar, is a useful selective medium for recovering Staphylococcus aureus from fecal specimen when investigating food poisoning. Okay, that is also very high yield. They can just bring this picture, then they tell you the label here A, and they say which kind of bacteria is this. So you remember it's Staphylococcus aureus. So we are done with the culture. We go to the biochemical properties. As you can see here, we have catalase. So as we had said, Staphylococcus is catalase positive and oxidase negative. Oxidase is also not usually done, but catalase is very high yield. It is catalase positive. It ferments glucose, lactose, maltose, sucrose, and mannitol with production of acid, but no gas. Okay, so this one will become very relevant when we're talking about the gram-negative bacteria. But what I want you to remember is it ferments all these glucose, lactose, maltose, sucrose, and mannitol. Okay, mannitol fermentation carries diagnosis significance due to this yellow pigment formation. Okay, then we have indole test, usually negative. This is also done in gram-negative bacteria. MR test. So MR here in this case is methicillin resistance. So it depends. Some Staphylococcus bacteria can test positive. So meaning they are resistant. So remember, when we are doing a resistance test, this means that the bacteria has mutated, okay? So when you do the methicillin resistance test, you're seeing if this methicillin, which is a type of antibiotic, is it going to work if you use it against this certain type of bacteria? If it is resistant, you cannot use that antibiotic. If it is sensitive, you can use that antibiotic, okay? So you're going to hear methicillin-resistant Staphylococcus aureus, MRSA. So it's a very serious case in the hospital, okay? Because it causes, we call them hospital-acquired infections. And this is because it is resistant to methicillin, which is a penicillin. And when that happens, we use a drug called vancomycin. Okay? Okay? I want you to remember that Methicillin-resistant Staphylococcus aureus, the test we use, the drug of choice we use for that is vancomycin. And then VP test. So VP test is a special type of test. The full name is, let me check the full name for you guys. It has a very complex name, but it is only used for Staphylococcus. So the VP test, this is never examined, but this is just good to know. Normally what happens is Staphylococcus usually breaks down glucose, releasing a product called acetoin. So this acetoin is what is going to turn this VP to be positive. So you can look it up. It's called Voges-Proskauer test. Okay. So it's detecting the acetoin, which is a byproduct of breakdown of glucose by Staphylococcus aureus. Then urease test is positive. It hydrolyzes gelatin, reduces nitrate to nitrite. Phosphatase is positive. DNA test is positive. Coagulase test is positive. So these are going to be the virulence factors we're going to look at in the next slide. Okay. How I used to remember Staphylococcus, it was the tests used for Staphylococcus aureus were almost all positive, especially the high-yield tests, which are the coagulase test, catalase test. Those are the high-yield tests, and they're usually positive. Then these are the good-to-know tests. Then the virulence factors. So we can divide them into three. We have cell wall-associated structures, extracellular toxins, and coagulase. Okay. So for the cell wall, remember this is a gram-positive. So the peptidoglycan, the capsule, so this is plus minus, and then protein A, which is very, very, very important, we're going to discuss, and then clamping factor, bound coagulase. For the extracellular toxins, we have hemolysin, leukocidin, enterotoxin, TSST toxin. So it's called toxic shock syndrome. So it's toxin mediated. Okay. Then exofolatin toxin. Then for the coagulase, these are the enzymes. We have staphylokinase, DNase, phosphatase, lipase, phospholipase, hyaluronidase, serokinase, protease. Okay. So in this, the most high yield is protein A. You have to know because they'll ask you, what is the function of protein A? Then the toxic shock syndrome, this one, TSST. And then these are the coagulase, the enzymes. So we start. So this is a brief slide of what is happening. Let's go into the cell wall. So the capsule, so anywhere you see a capsule, so these are for some strains of Staphylococcus that have a capsule. Its function is to resist phagocytosis. So phagocytosis is the process where a macrophage engulfs a bacteria. So it's going to resist and adheres to the host cell. Peptidoglycan inhibits inflammatory response. So what are the inflammatory response in this case? So things like fever, hypotension, histamine release, neutrophil chemotaxis, those are the inflammatory responses. Then protein A, as I said, very important. It binds to the Fc moiety of IgG, exerting anti-opsomin. So what is the function of this anti-opsomin? The function is to inhibit complement activation, okay, and anti-phagocytic effect. So similar to the capsule. So it inhibits complement activation and phagocytosis. Okay, just remember that. Protein A binds to the Fc portion of IgG, inhibiting complement activation and phagocytosis. That's very high yield. And then clamping factor, causes organisms to clump in the presence of plasma bound coagulase. So it binds together. Okay. And then we have the extracellular toxins, hemolysin. So from the word hemolysin, coming from the word hemolysis. So hemolytic, dermonecrotic, and leukocidal. So it breaks down. Dermonecrotic means it's breaking down the skin tissue. So you're going to see there's a condition which is known as necrotizing fasciitis. So basically what it does to the skin, it breaks down the skin layers, okay? The epidermis. Then leukocidal, meaning it's killing the leukocytes, the WBCs. Then leukocidin, it kills the WBC. Enterotoxin acts on ANS to cause illness, autonomic nervous system. Then here the most high-yield one is toxic shock syndrome toxin. So there's a disease called toxic shock syndrome. It's a super antigen. Okay. Normally, the disease causes fever, skin rashes, diarrhea, conjunctivitis, and earth to shock. So we're going to look at it when you're looking at the symptoms, but you have to remember it is mediated by the TSST. And then we have the exfoliating toxin. From the word exfoliating, so meaning there's some exfoliation happening. It breaks intracellular bridges in the stratum granulosum of epidermis and causes its separation from underlying tissue, resulting in blistering and exfoliating disease of the skin. Okay. So we're going to see, basically it's destroying the skin structure. So I think I have a picture here. As you can see, these blisters. So due to the destruction of the skin structures. And then the enzymes, coagulase. Anytime you see coagulase, function of coagulase is to break down. It converts fibrin to fibrinogen. So clots plasma by acting along with CRF present in plasma, binding to prothrombin and converting fibrinogen to fibrin. Okay. Then staphylokinase degrades fibrin clots so that you bleed. Okay. So anytime there is a clot, it wants to break it. Hyaluronidase hydrolyzes the acidic mucopolysaccharides present in the matrix of connective tissue. DNA, lipase, phospholipase, protease degrades DNA, lipid, phospholipid, and protein, respectively. So ACE is ACE is the enzyme. So all of them cause destruction. Okay, so this can come as an essay where they tell you outline the extracellular enzymes and their functions in the pathogenesis of Staphylococcus aureus causing disease. So you just write all these 1, 2, 3, 4, 5, 6, 7. You already have 7 extracellular enzymes. Okay. Then pathogenesis, this is how the disease occurs. So the Staphylococcus will adhere to the damaged skin, mucosa, or tissue surfaces. At these sites, they evade defense mechanism of the host, colonize, and cause tissue damage. Remember, we said that this Staphylococcus is found on the skin. So once there is an opening of the skin can occur when you have something like a tear or a slight injury. The Staphylococcus will now go and colonize the skin. Then through its toxins and multiplication, it's going to stimulate inflammation. Then through these virulence factors is how it's going to get destruction of the skin. Then the syndromes, this is just a good summary. We have stye, usually on the eye, boils, carbuncles, can cause sinusitis, panicles. Then hematogenous spread, meaning when it spreads in the blood, it can reach the heart, causing endocarditis, goes to the lung, causing pneumonia, goes to the stomach, causing emesis or vomiting, skin, causing impetigo, and then diarrhea, which is normally found in the toxic shock, Staphylococcus toxic shock syndrome, the TSS. And then shock syndrome, it can also cause a UTI. Then when the bacteria moves up to the bladder, it causes cystitis, which is inflammation of the bladder. Then scalded skin syndrome, then it can cause osteomyelitis. Okay. So osteomyelitis is a bacterial infection of the bone. So this is a very good summary. Now let's go into the individual diseases or conditions. We can divide them into 5. Number 1, in fact, we can divide them like this into cutaneous infections, deep, exfoliative, toxic shock, and staphylococcal food intoxication or food poisoning. For the cutaneous, the most high yield I want you to know is impetigo. It can also cause the rest, but the most high yield is impetigo. For deep, osteomyelitis, periostitis, endocarditis. Then 3, exfoliative. 4, toxic shock syndrome. 5, staphylococcal food intoxication or food poisoning. Cutaneous folliculitis, inflammation of the hair follicles. As you can see here, this is a pimple or a bump. Okay, this is the normal hair follicle, but when now the bacteria seeps and goes to the hair follicle, causes inflammation. Then there's WBCs that come and cause the bump or the pimple. And then the sty, I'm sure you've seen this. It's quite common. There's a raised surface on the upper eyelid. Normally, the most common culprit for this is Staphylococcus aureus. Normally, they'll say you just put a warm compress of this, and then you just, it's going to be all right. Okay, so this is quite common. And then we go to funucles or boils. Funucle is deep-seated infection originating from folliculitis if the infection extends from the follicle to the neighboring tissue. As you can see here, it's usually very, very painful because it's in the deep tissue. The underlying cause is in the deep tissue, commonly found on the neck, armpit, and the groin areas. Then carbuncle. Carbuncle is aggregation of infected funucles. So for example, if you have a funucle, another funucle, another funucle, it forms a huge carbuncle. As you can see here, this is the neck. So a large area of redness, swelling, and pain, punctuated by several sites of drainage paths. Then impetigo, as I had said, this is very high yield. Superficial skin infection, and it is normally common in children. So as you can see, this child, from this, can you see them? They are honey-colored crusts. Can you see them occurring here? So if you just see this, let's say they bring in the exam, they're going to ask you what bacteria is most common. So the answer is Staphylococcus aureus. Another one is Streptococcus pyogenes that can also cause this. But the high yield is this honey-colored crust. Even if they bring in an MCQ, they tell you that a patient had honey-colored crusts on the surface of the skin. This is impetigo. Okay. These are the vesicles, pustules, and sharply demarcated region of honey-colored crusts. Okay. Then for the deep infections, we have osteomyelitis. This is inflammation of the bone, quite common. This is actually, if you start your orthopedics rotation, they'll tell you an orthopedic's worst nightmare is not even a fracture. It is actually osteomyelitis. It is one of the worst conditions that can occur in a patient. Okay. So bacteria can get to the bone via bloodstream following an injury. Clinical features: pain, swelling, deformity, defective healing in some parts, in some cases, pus flow. So as you can see from this X-ray, look here, observe at the level of the ankle or the posterior, the proximal tibia. Can you see? Look at how the healing has occurred. So that is what we call osteomyelitis. Okay. Then we have periostitis. Periosteum is the bone, the inner bone. It can cause inflammation there. So fever can occur, localized pain, and leukocytosis. So leukocytosis means that there is elevated leukocytes in blood. So diagnosis, needle aspiration of subperiosteal fluid. And then we have endocarditis. So Staphylococcus aureus is a very bad cause of something we call acute pericarditis endocarditis. Okay? Acute endocarditis. It's very bad because what happens is you have a healthy heart valve and the bacteria just comes and settles on your valves. Okay? And when it settles here, it starts growing. And when it starts growing, it causes damage to the heart valves. Pumping becomes an issue, and there's an area of inflammation here. Okay? So you usually have a very normal heart. But as we're going to see, for Staphylococcus epidermidis and the rest, they can't cause endocarditis, acute endocarditis. Okay? They cause less of an infection. Then for exfoliative disease, to exfoliate means to scale off, or basically the skin is peeling. Okay? It's also known as staphylococcal skin scalded syndrome, SSSS. Okay? SSSS, staphylococcal skin scalded syndrome, previously called dermatitis exfoliative. These are the names. Epidermal toxin produced by Staphylococcus aureus at skin and is carried by the bloodstream to the epidermis, where it causes a split in the cellular layer, i.e. the toxin separates outer layer of epidermis from underlying tissue. As you can see in this child, how the skin has sloughed off. Okay. So if you brought this picture and you're told what causes this, the bacteria is Staphylococcus aureus, but the exact virulence factor is the toxin. Okay. That is the toxin that is causing this, the scalded skin syndrome. Then we have the toxic shock syndrome, the TSST. It is caused by Staphylococcus when it enters the bloodstream. Okay. So it's a multi-system illness characterized by high fever. Basically, when there's bacteremia, headache, vomiting, diarrhea, conjunctival redness, hypotension, which is low blood pressure, skin rashes, and then organ failure. So it can cause kidney failure. And then one thing they like asking here, they'll tell you in a patient where they have used prolonged use of vaginal tampons, okay, or nasal packings, okay. So when you see tampons, someone has used tampons for a while, just remember that is toxic shock syndrome, okay. Or nasal packings where we have, is it wool they put on the nose? Or sometimes you can have surgical wound packing. So where there's a wound and then they put the packing there, then they close the wound, okay? Those are buzzwords for toxic shock syndrome. And then Staphylococcus food poisoning. What I want you to remember here is it is not the bacteria that is causing the food poisoning. It is the endotoxin, okay? Not the bacteria. And normally what happens is you'll consume food. Let's say, for example, you left food at room temperature for several hours. So in the exam, they can give you like a picnic situation. And then when you see food is left for several hours, the Staphylococcus preformed toxin, the endotoxin, is what is going to cause these symptoms. So usually around 2 to 6 hours, you'll start having nausea, vomiting, severe abdominal cramps, diarrhea, sweating, headache. And one thing to note is the diarrhea is usually non-bloody. Okay? Non-bloody. Are we clear? Then maybe something to add is this toxin that is produced by the Staphylococcus is heat stable. So even if you cook the food, it's not going to be destroyed, okay, by cooking. So it's really, really bad when staphylococcal food poisoning happens. Okay, I hope we're clear on the diseases it causes. And then we have mode of transmission, a person with lesions, so through contact. Remember, it just requires a break in skin and it will enter the body. Airborne droplets, asymptomatic carrier can give you, then cross-infection. Prevention, wash your hands, keep wounds covered, because if you expose your wound, the Staphylococcus aureus can easily enter. Reduce tampon risk. So remember I said prolonged use of tampons can cause the toxic shock syndrome. Avoid sharing personal care items, cooking and storing food properly. So don't leave your food in room temperature. Then treatment, we have antibiotic therapy. So you have to do sensitivity testing. If it is resistant to methicillin, we use vancomycin. Wound drainage. So in case an abscess has formed, an abscess is basically a collection of pus. We have to drain the wound. Device removal. So in this case, if you're using tampons or nasal flares, the nasal packs, you remove them, and then removal of dead tissue. Remember when the bacteria can cause necrosis of the skin. So you have to, we call it debridement. We usually go clean this area. And then some lab diagnosis. So one thing you should remember in bacterial infections, the neutrophil count is usually high. Okay, so one, the WBC count or the total leukocyte count is usually high. Normally is between 4 to 10,000, or sometimes you can use 11,000, 4,000 to 11,000 cells. And then the neutrophil count is usually 80%, usually very high. Okay. Investigations. If you're going to be asked which specimen do you use, you can culture the pus, nasal swab, food, blood, sputum. Okay. So how to remember is you have to know which system does Staphylococcus infect. Then you look for the specimen in that system. Okay. Then culture, we had said, you go specimen are cultured on blood agar. Then as you can see here, there is beta hemolysis. After incubation, you do gram stain, then you observe on a microscope. Then you do the coagulase test. After doing the coagulase test is when it's going to tell you, is it Staphylococcus aureus or is it Saprophyticus or Epidermidis? Okay. As you can see here, coagulase test, what happens is you put plasma, then you put the specific specimen, intubate the mix in water bath at 37 for 3 to 6 hours. If it clots, then it is coagulase positive. It has the enzyme coagulase causing this clotting. If it doesn't, it's coagulase negative. Then methicillin-resistant Staphylococcus aureus, MRSA, as we had said, it's a very huge challenge in the health industry. In fact, there are some countries, like for example, my friend was telling me, she was planning to travel to a country in Europe, and they made her test for this bacteria, methicillin-resistant Staphylococcus aureus. definitely should not have. It's okay, it's not definitely, but hopefully, or God willing, she does not have it, because if she has, she won't be able to travel to that country because we are out of new types of bacteria, sorry, of antibiotics to use. So the resistance is attributable to beta-lactamase production due to genes located in the extra chromosomal plasmids. Remember last time when we were saying plasmid, anytime you hear the word plasmid, you know that it is encoding for resistance. Okay? The plasmids is where the bacteria stores its gene for resistance. So some are resistant to the newer beta-lactamase resistant semisynthetic penicillin, such as methicillin, oxacillin, nafcillin. Resistance is due to the presence of unusual penicillin binding protein in the cell wall of resistance strains. This is also very important. They can ask you the mechanism of resistance. Okay. So at this penicillin binding protein, usually found in the peptidoglycan, there is usually a resistance to the proteins. So it is conferred by this gene that is found in the plasmid. It's known as MEK-A gene. Okay. And then infection with MRSA is likely to be more severe and require longer hospitalization, with incumbent increased costs than infection with a methicillin susceptible strain. And drug of choice, vancomycin. There's also another one. If you get vancomycin-resistant Staphylococcus aureus, you now go to a third line called linezolid. Okay. Are we clear? Then coagulase negative. So from this, we are done with Staphylococcus aureus. So yeah, where's our picture? Yeah, we're done with this side of the table. Now we're going to this side, the coagulase negative. We have Staphylococcus epidermidis and Staphylococcus saprophyticus. These will be fast. So Staphylococcus epidermidis causes infection of native heart valves and intravascular prosthesis. Basically, what this means is you will have a person will come to you and let's say, for example, they have a bad valve, okay? A bad heart valve. Let's say their mitral valve is not working. So they have a device, okay? So this Staphylococcus epidermidis, remember, this is normal flora of the skin. It occurs in the skin naturally. So this one, once it enters the blood and then it goes to the device in the heart, it will now form, it's now going to form clusters at the valve, okay? And once that happens it's going to cause endocarditis, okay? So this is very high yield for you to know, Staphylococcus epidermidis. It causes infections on the heart valves and intravascular prosthesis. So prosthesis means, let's say, for example, you're having like a catheter. It's going to form a biofilm. You remember, who remembers what causes the bacteria to adhere to the catheter? We had said that last time. What structure in the bacteria causes adherence to the catheter? Type on the chart. And then saprophyticus, this is very high yield. It causes UTIs, mainly in sexually active women. Okay, they'll give you in the exam, the patient is sexually active and then she came in with a UTI. The answer is saprophyticus, Staphylococcus saprophyticus. And then one thing you have to note is, you see, normally when you're having your UTI, they usually do something known as the nitrite test. Okay? Saprophyticus is negative for the nitrite test. it does not reduce nitrates to nitrites. The most common cause of UTI in females is E. coli. And E. coli causes reduction of nitrates to nitrites. So if it's negative for nitrites, usually Staphylococcus saprophyticus. Another one we're going to see is Enterococcus. Those two, they cause UTI and they're negative for nitrites. Okay. No one has typed the chart on the chart. What causes adherence to catheters? What cell wall structure? Have you forgotten? Pili? No. Did you say pili? Do you remember saying something like slime layer? Have you remembered? When we talked about the slime layer. So it causes the biofilm formation. Okay. Pili, remember we said pili, there are two reasons for pili. Number one is for the sex pillars that forms during conjugation. And number two is adherence of the bacteria to the cell surface. Surface of the cell, not the catheter. Pili is for the surface of the cell. When it enters your body, the cell, it's going to attach there. That's the function of the pili. Okay. And then maybe just to mention, drug of choice for Staphylococcus saprophyticus, we usually use vancomycin. Sorry, no, epidermidis is what we use vancomycin, because most of the time you'll find that it is resistant to penicillin. So we just give vancomycin. Then for saprophyticus, since it causes UTI, we use nitrofurantoin, and you can also use fluoroquinolones. Okay. So what tests do we do to distinguish these two? Staphylococcus epidermidis and saprophyticus. Let's say you get a sample. What test will you do to distinguish these two? Nitrate, no, but both will be nitrate negative. What test do we do? Good. So we do the novobiocin test. So which one is resistance? Saprophyticus. So I remember how I used to remember back in the day, I used to say saproresistance. So it's resistant to novobiocin. But epidermidis is sensitive. I'm seeing a question. Sorry, what of Cipro and Doxy drugs? I don't understand that question. Okay, let me repeat. Drug of choice for epidermidis, vancomycin. The reason we do that is because most of the time, epidermidis is usually resistant to penicillin. So we give vancomycin. Drug of choice for saprophyticus, because it is a UTI, nitrofurantoin, which is very common for UTIs, and fluoroquinolones. So fluoroquinolones are the ciprofloxacin, levofloxacin, those ones. Okay. I think I'm done for Staphylococcus. Any question?